Okay, we're going to go ahead and get started. I'm Maryann Davis from the University of Massachusetts Medical School, and from the very long title of our center, it's the Learning and Working During the Transition to Adulthood Rehabilitation Research and Training Center, which is funded by the National Institute on Disability and Rehabilitation Research. We have the pleasure now in this next session of talking about mental health issues for young adults. And I have to say what a pleasure it is to be among folks who are really interested in young adults. This has been a field of research that I've been doing for almost 20 years now, and typically there aren't many people who are focusing either beyond adolescence or anything except broadly adults. And so it's been such a pleasure hearing talk after talk. And maybe people after people saying we don't have enough research, which we will ding that bell as well. There's not nearly enough research to help us understand how to deliver good mental health care to this age group. So let me get started. So one of the first questions, just to let you know what we mean by mental health, and it's a very broad term that can be used in a variety of ways. If you go in to get treatment, sometimes you're going in because you're having relationship problems. Is that a mental health condition? Well, you're having relationship problems. But typically when we're talking about mental health as a health condition, we are talking about disorders as defined by the DSM or the ICD, depending on which system you use. And in some ways, it's easier to say what it's not. It is all what we think of as mental health conditions, bipolar disorder, major depressive disorder, but it does not include cognitive disorders like dementia. It doesn't include substance-related disorders. It does not include disorders due to a general medical condition that have to do with the way you're thinking or feeling. It's not sleep disorders. And then there are a whole host of what we call adjustment disorders, which are clinically significant reactions to stressors. So usually when we're talking about mental health conditions, we're referring to like everything else in the mental health domain of the DSM. And Bill Copeland's going to be talking a little bit more about some of the more common mental health conditions. And then Larry Seidman's going to be talking about, thankfully, the most rare of mental health conditions, but also the one that's most serious, that's psychotic disorders, schizophrenia in particular. So I want to make, I think, 3 points in my 15 minutes. I'm going to tell you what they are, so maybe you'll remember at the end. One is that mental health as a health condition disproportionately affects young adults relative to other health conditions. The health condition for young adults is mental health. So that's point one. Point two is we have lots of evidence-based treatments for mental health disorders. We have none in this age group. And point three is the way that we've configured our systems into separate child and adult systems makes it particularly difficult to develop good mental health care with continuity and quality. So those are the 3 points that I'm going to make and hopefully show you some data so that you think that I'm just not stating these things, we actually have some research behind them. So the World Health Organization conducted a global burden of disease study in 2004, and in 2011, Fiona Gore and colleagues published the findings looking at the burden of illness in youth, for them 10 to 24-year-olds. When they looked at young adults, in this particular case, 15 to 24-year-olds, they had identified sources of death and disability as the burden of illness. Combined, the mortality and disability is the overall burden. And the point that they made in looking at, I think it was like 153 countries, is that in young adulthood, unlike in mature adulthood, the primary public health burden is disability, not mortality. Although mortality is always the most negative outcome, the proportion of the burden comes from disability. And that in high-income countries like the United States, over 80% of the total disease burden is attributable to disability caused by the medical condition. Now, Fiona was generous enough to share the data that they had collected with me and allowed me to analyze data for specifically the United States. They haven't published on this yet. So this is, you guys are the first to see this. When we look at the major causes of burden due to disability in the United States in 15 to 24-year-olds, let me walk us through here. These are all the various health conditions that they looked at. I've made mental health and substance use very brightly colored. In combination is what we refer to as behavioral health. And when we look at females who are 15 to 19 and females who are 20 to 24, clearly out of the entire burden of illness produced by these various conditions, it is disproportionately mental health. Primarily bipolar disorder, major depressive disorder, and schizophrenia. A smaller portion for young women is caused by substance use disorders. Now, as we've been talking about all morning, the case is a bit different for males. There still is a big chunk that's accounted for, that's the word, by mental health, but a disproportionate by substance use. Between mental health and substance use, these are the disproportionate health issues in terms of causing disability in young adults. Okay. Now, one of the differences between mental health care delivery and medical health care delivery is that the nature of the intervention, other than the psychopharmacology, other than being given a medication for a particular disorder, for most mental health care, the best care is a combination of psychopharmacology with psychotherapy. Some have a little bit of weights going towards one or the other, but typically it's both. Psychotherapy is a psychosocial intervention. It's an exchange between a counselor and a young person, or a counselor and a young person and their family. Because of the nature of that intervention, this psychosocial development that's occurring during young adulthood has a direct impact on the treatment that we provide. So the treatment that you provide somebody who's 40 years old, maybe for kidney stones, might be the same medical treatment you provide to a 20-year-old with kidney stones, but it shouldn't be the same psychotherapy because of the very differences in the psychosocial development of this age group. The other aspect that is very different that we've talked about all morning is the very changing role of families during this stage of life. Young adults are different from mature adults in the level of involvement of their families. They're also different from younger adolescents. It's a unique stage of life. There's a very delicate dance going on between developing independence, interdependence, self-determination, being related to your family, taking advantage of the resources that they can provide to you, while also trying to find yourself and your own independent means. That also has an impact on care. Psychotherapy in children and adolescents primarily leverages the parents to help make the changes. As soon as you're 18, it's not going to work as well. And yet it's not reasonable to not involve family in helping young people recover from the mental health conditions that they're trying to address. Okay. As an example of some of the ways in which the target behaviors that you might want to intervene with differently in young adults might look from adults, there are a couple studies that have looked at suicide. And they have found that the first study is with younger versus older veterans. And in younger people who have committed suicide, they found higher levels of non-alcohol substance problems. At the time of suicide, they had higher blood alcohol levels. The presence of problems in the younger adults was more relational, and the older adults who had committed suicide were more financial and medical health related. Different causes and correlates of suicide. In another study of general young people and mature adults, at younger ages, suicide was more associated with impulsive behavior. Impulsive and aggressive behaviors were not associated with suicide in older individuals. And so as you're developing interventions to try to deal with, say, suicidal ideation in young adults, it should look different from the intervention that you're developing for more mature adults or from younger children. One of the other aspects that affects any treatment, whether it's medical treatment or mental health treatment, is it's important to go to the treatment, and then it's important to stay in the treatment long enough for it to have an effect. Overall, we have, there's data to suggest that young adults are most likely to drop out of mental health treatment compared to adults. We had some data from a community mental health center in Worcester, which is a fairly typical community mental health center, and we compared what we were calling transition age youth, 16 to 30-year-olds, to adults, younger adolescents, and children. And this is a survival curve showing the proportion that remain in treatment. And what we see is for the transition age population, they are leaving treatment more rapidly than any other age group, and the fewest number of them remain at the end. So one of the keys that we have is to try to help young people, A, come to treatment, and B, remain in treatment. we have no research that tells us why young adults might be leaving treatment at a more rapid rate. If you ask young adults, they'll give you a whole host of answers, including loss of health care coverage, including having a whole lot of other stuff going on in their lives, and mental health treatment doesn't seem very relevant to their lives, including feeling like it's not helpful. But we don't have any systematic research that would really help us develop interventions to help them stay in treatment long enough for it to have an effect. Okay. So the reason that we don't have evidence of efficacy of mental health treatments in this age group is, and we do in other age groups, is that when we conduct clinical trials across various ages, like you do an adult clinical trial, and you read about them in the manuscripts and or in the publications, and they'll say subjects were 18 to 55 years old, and then here are our results. And we have no idea how well those 18 to 24-year-olds did or 25-year-olds did. And actually, when you look at their numbers, sometimes you see extremely small numbers of young adults in adult studies. And so you can't take those findings and say, I bet you for all of those young adults, that's effective. Very few of those studies have the sample size to conduct an age difference study. And for those that have, so not many actually have published those age differences, but there are some, and there are some studies that have done so, and we see that they have found some age differences, which I'll tell you about in a minute. The other way that we get evidence-based treatment for this age group is to develop and test the intervention in that age group. Most commonly, we do this with college mental health. It's where the young people are conveniently located, and we happen to be doing research there because we live on college campuses. Even for college mental health, there's not evidence-based treatment yet. Now, the other area, and we're fortunate to have Larry Seidman here talking about early intervention psychosis, because that happens during late adolescence and early adulthood. It is an intervention that is developmentally appropriate, because if you're going to do for early intervention, psychosis is primarily going to be in young adults. But other than that area, we don't have evidence-based treatments for young people. Okay, and let me just show you very quickly an example of analyzing by age group an adult study. This was a study of supported employment, which is the strongest evidence-based intervention to help adults with psychiatric disabilities be employed. What we see over here, the analyses, this was a randomized clinical trial between a control condition and supported employment. And the data were analyzed for young adults, 18 to 24, older young adults, 25 to 30, and then those over age 30. And this result is what you see published in most publications about supported employment, is it looks like it gets you a great result compared to services as usual. We're going to skip the middle for a minute. And if you look at the youngest adults, if you publish that, basically there is no effect of this evidence-based treatment for the youngest adults. And this middle group, who the heck knows what's going on with that? It looks like you get a super effect for 25 to 30-year-olds, although before embracing this, this was the report of having been in any paid employment over a 12-month period. And we know among young adults, one of the things that happens is that they change jobs very rapidly, and it's not clear that having had one may have lasted for very long. So we don't want to embrace it necessarily, but it's evidence to suggest that we would want to look at this evidence-based treatment much more closely in young adults before saying it's something that we should apply there. Okay. So I'm going to tell you very quickly about some of the common themes in developmental adaptations. There's a lot of research right now that is putting together manualized interventions specifically to deal with this age group and their mental health conditions. There's all of the studies at this point are very early stages of research where they're developing the manual, they're doing the feasibility testing, they have small clinical trials, we don't have any large ones yet. But some of the adaptations that are being made to existing interventions is the central involvement of youth voice. No point in doing an intervention if you're not partnering up with a young person to make sure that this matches what their interests and motivations are. There's the involvement of peer mentors, peer coaches, peer specialists. The particular impact that peers have in this age group is that we're trying to leverage that to get better outcomes. The struggle to balance youth versus their family involvement. We don't have good guidelines yet about how to bring parents in or grandparents in to help in treatment, while also trying to help a young person develop their self-determination skills. But people are working on it. And that they all emphasize this in-betweenness, that they're simultaneously working and going to school, living with family while striving for independence, finishing their schooling while parenting, etc. And lastly, let me just talk very quickly about the system. For the youngest adults, so we parse our systems by policy and payment structure into child systems and adult systems. Not very many of them really walk across very smoothly. Let me give you the example of mental health, which is where I live. Child mental health, target population definitions and eligibility criteria are different from adult mental health, public mental health systems. Typically, adult mental health systems criteria are much more narrow. It makes for a young person who's receiving even intensive children's mental health services as a late adolescent, some group of them is not going to get in the door of adult services simply because they've had a birthday. Nothing has changed about their need or their condition, but they no longer qualify. So we have that issue that goes on. We also have the issue that because we've parsed our systems up, that when you're working with young adults, you can hit absolutely every single one of these arrows. And as somebody who's providing services, that can make for very fragmented types of services and service coordination, as well as knowing and partnering with other treaters and other systems. And then lastly, we train our professionals to provide either child care or adult care, and we don't have professional training for people who know how to work with young adults. And so it provides another systemic barrier to delivering good mental health care for this population. I'm going to skip that, although it was really good. And go on to the Affordable Care Act. We've talked about it a little bit, and there are all these ways in which it should help young adults. What I want to say is we got to watch this baby really carefully over the next several years. If you take a young person who has recently been discharged from inpatient treatment who has bipolar disorder, and you say in the next 6 months, well, your Medicaid eligibility is going to run out, but you could qualify under this other program, are they going to go and apply? No. Are their parents going to go make them? Hopefully, maybe they're going to help them get there, but their parents might not even know, or they're living in a different state. And to expect young people to to get themselves organized, know about these complex rules, and get themselves health care, I have great concerns that yes, it will provide for folks who already have pretty good safety net systems, but for those who don't, they're still going to be running out of health care. All right, so just very quickly in conclusion, mental health and substance use disorders are the most impairing health conditions of young adulthood. They need age-tailored services and interventions, but we don't have them for them yet. There are numerous interventions in development. That's a good thing. The system is fragmented in which we're going to deliver those kinds of services at that point of entry into adulthood in ways that make it very complicated to cite those evidence-based treatments once we have them. Fragmentation contributes to discontinuity in care. The Affordable Care Act presumably will help, but it's not sufficient. And we need a huge amount of research to help us understand what the appropriate targets should be for this age group, what are interventions that appeal to them, that get them into treatment, that help them stay in treatment, and what do we do when they're actually getting the treatment. And we need to test these system interventions on a larger scale. So that's our overview of mental health. Bill Copeland is going to talk some about the occurrence and emergence of mental health conditions, service utilization, and functional outcomes.